The management of cholesterol has shifted from let's get control of the cholesterol to let's get people on statin. I want to start off with the pathophysiology of cholesterol and then move into statin therapy and have that be the major part of this discussion. Who gets a statin, who shouldn't get a statin, and what do you do when things go wrong? And then we'll finish up with a review of all the other medications that can be used to control cholesterol that you use when statin therapy doesn't work. I start off with the pathophysiology first. This is the system as I want you to see it. It's the liver, and this is the bloodstream. There's two types of cholesterol. There's LDL, which is the bad cholesterol, and there's HDL, the good cholesterol. Right. What does that mean? Well, the LDL is the stuff that takes cholesterol from the liver and brings it to the periphery. Now, cholesterol is actually good, right? Every cell in your body needs cholesterol. So having cholesterol isn't an issue. Having too much cholesterol, though, is a problem. Here's how I want you to see the LDL. All right, there's this worker who's got this bucket, right? And he's bringing cholesterol out to the periphery. That's good, right? Cells need cholesterol. But if there's too much cholesterol, it starts to overflow. And if it overflows, you get a cholesterol plaque. Now, cholesterol plaques are the things that cause vascular disease. Myocardial infarctions, strokes, peripheral vascular disease, and carotid stenosis. Any one of those things is vascular disease, and vascular disease comes from cholesterol plaques. The HDL is the good cholesterol because it takes these excess plaques and brings them back to the liver for processing. So teleologically, it makes sense. If HDL is the good cholesterol that's clearing plaques, you want to increase the HDL. And if LDL, the bad cholesterol that's causing the plaques, you want to decrease the LDL. That made sense? That's what we did. But now we do statins. Okay, this is all evidence-based and it's population medicine. That is, all comers do this. You may have to individualize your statin therapy for your individual patient. When it comes to answering questions and picking which drug should you use, we use the population. Now, if it ever comes up, the number one thing to do for cholesterol is lifestyle, which is diet and exercise. And the second thing is adherence. Are you actually doing the things we ask you to do? Whether that's medication adherence or lifestyle adherence, that's what you go for first. But there are certain people who must be on a statin. There's 4 categories. Who are they? So you're going to start a statin in anyone with vascular disease. It doesn't matter what else you have. You got vascular disease, you're on a statin. And vascular disease is MI, CVA, PVD, and carotid stenosis. The second group is anyone with a really high LDL. Get them on a statin. The next 2 groups, there's a lot of modifiers, so you have to pay attention. If someone doesn't have the LDL requirement, that is, their LDL is between 70 and 189. It's not really low, but it's not really high. They get a statin if they're the right age and they have diabetes. The age is 40 to 75. The fourth category is very similar, so pay attention. The LDL is 70 to 189, so not really low and not really high. They have the age, and they have a calculated risk. That's high. The age, 40 to 75. So these first 2 things are the same for 3 and 4. The only thing that's different is, do you have diabetes? Or do you have a risk score that's high? What's the risk score? What is that? You're not going to have to calculate the risk. You can log on and use the calculator. It's incredibly flawed, but the idea is, what's a 10-year risk of this person dying from a heart attack? So what are the risk factors for heart attack? That's what goes into the calculator. You're going to be looking at things like hypertension, smoking, obesity. And we've already considered dyslipidemia because we're talking about statin therapies. And we've already considered diabetes because it was in number 3. Now, the other things are going to be age, greater than 45 for a man, greater than 55 for a woman, and family history. So you put all these things into a calculator, they give you a score. Don't worry about the score percentage. Just recognize who gets a statin. People who already have disease. People who have really bad LDL. If your LDL isn't that bad, but it's not good either, then if you have diabetes or a lot of risk factors for heart disease, you get put on a statin, so long as you're between the right age. And the goal is always, always high intensity statin. There also is moderate intensity and low intensity. I'm going to write them up here because I want you to hear them and see them, but it's not worth memorizing all of them. I'll show you which ones you should memorize, the ones listed in green. High intensity statin is atorvastatin at a dose of 40 to 80, or rosuvastatin at a dose of 20 or 40. Atorva rosuvastatin, divide by 2. Moderate intensity is the same drugs, atorva and rosuva, at a lower dose. And since that's the minimum these drugs can get, there's no low intensity version. Okay. For high intensity, that's all there is. There's some other statins you can pick, but they won't count as high intensity. So the other statins that you have, but you shouldn't necessarily memorize, are going to be simvastatin, pravastatin, and lovastatin. Simba, Prava, Lova. Recognize their names, but don't memorize them. Okay, I didn't say those dosages out loud on purpose. They're there, you can look at them, but I don't want you to memorize. I want you to memorize high intensity statin is atorvastatin, rosuvastatin at 40, 80, 20, 40. Moderate intensity, atorva, rosuva, 10, 25, 10. Everybody should be on high intensity. So why even bother talking about moderate and low intensity? Well, there are certain people that have to go onto moderate intensity. And the whole goal of lipid guidelines right now, whether you agree with them or not, and it's controversial, but this is what we're being tested on, the whole goal is to get someone on a statin. So even if there's a good reason they shouldn't be on a statin, you still put them on a statin. You just do lower dose. The reasons to put someone on a moderate intensity statin, and this is a simplified list, is going to be age greater than 75, someone with statin intolerance, or they have other comorbid conditions in which medication conflicts and drug-drug interactions may not work. What the hell does that mean? Liver disease and renal disease. All right, it's a lot of memorization. So I'm going to say it again, just so it sticks. You have vascular disease, high intensity statin. You have really high cholesterol, over 190, high intensity statin. You don't have low cholesterol, I wonder if you need a statin. Are you kind of old and have some vascular disease risk? High intensity statin. You can't handle a high intensity statin for whatever reason, still put you on a statin, just at a lower dose. All right, so what then do you need to do before and during statin therapy? It used to be that we checked very frequently LFTs and CK levels because we know that statins can cause myositis and hepatitis. Turns out that you just order a bunch of tests and you didn't really need to do anything about it. So here are the new recommendations. You do need baselines, right? And that's very useful because you need to know, is the statin doing it? So before you start someone, what you're going to do is check the lipids, of course. That's how we start the whole process to begin with. an A1C to make sure they're not diabetic, because if they're diabetic, they're going to get put on a high intensity, and the CK and LFTs. Right? You want to know what they were before you started statin therapy. And then you're going to say, okay, do we need to do routine assessment of these things? Lipids can be checked at a year. A1C only if diabetic. You don't need to continually assess the A1C. And you do not routinely check the CK or the LFTs. No need to do that. You do check them when you develop symptoms. If you have muscle soreness, weakness, muscle pain, check a CK and a UA to make sure you're not getting rhabdo. And if you have hepatitis symptoms, check LFTs. What do? Statins cause trouble. If you get statin-induced myositis or any myopathy associated with statins, stop the statin. If you get statin-induced hepatitis, what do? Stop the statin. That makes sense. But the current lipid guidelines say, put them back on statin once it goes away. Just go to a lower dose. Once you get over the problem, restart at a lower dose. Remember, statin intolerance went from high to moderate intensity. And that's statin intolerance, myositis or hepatitis. Okay, so that's statins. We're going to leave this board, so I want to review it one more time. I'm really hammering it home. Who gets a statin? Let's talk to you in a different way. Everybody gets a statin. If you have disease and you're over 40, you get a statin, like any disease. The only person who doesn't get a statin is if their cholesterol is really well controlled. If your LDL is less than 70 and you have no disease, chances are you're not getting a statin. They're probably not going to be mean to you and give you a 39-year-old person. So if you have vascular disease or an LDL greater than 190, it doesn't matter what your age is, doesn't matter what your comorbid conditions are, statin. The wild card comes in when you're between 40 and 75 and LDL between 70 and 189. So what you're looking for is LDL less than 70. Chances are they'll have no vascular disease, no statin. You're also looking for an LDL greater than 190. Doesn't matter, get a statin. Here's where you want to spend most of your time memorizing to get the answer right. High-intensity statin is atorvastatin or rosuvastatin. All these patients are supposed to get high-intensity statin unless they can't handle it, greater than 75, statin intolerance, liver and renal. The way you get them there, though, is to start them at moderate intensity and work your way up to high intensity so they don't get statin intolerance. Statin intolerance is myositis and hepatitis, in which case you stop the statin, but resume it at a lower dose. Now let's talk about those medications that we used to use, but will still pop up on the test. So to speed up this next part, I've already written them on the board for you. I'm just going to breeze right through them. Statins we talked a lot about. They lower the LDL but can cause myositis and elevation of the LFTs. Fenofibrates like gemfibrozil will lower the total cholesterol but increase the HDL. Right, so they used to be really good. These are second line. Use fibrates when statins are not able to be used. They also cause myositis and elevation of the LFTs, so generally you don't want to use them together, statins and fibrates. Ezetimibe and bile acid resins essentially eliminate LDL through the GI tract. Remember, you have to eat cholesterol to get some cholesterol in your bloodstream. So they basically block absorption of bad cholesterol, but because of that, they cause an osmotic load in the gut, leading to diarrhea. Ezetimibe, diarrhea, that's one of the key things they like to test. And finally, niacin. Niacin, if you look at its good effect, it sounds like it's great, right? Based on the pathophysiology, it increases the HDL, that's good. It decreases the LDL, that's great. But in practice, niacin didn't really do anything. But it has this really cool board association that keeps getting tested. So if you see the word niacin, you should think flushing. And in order to get over the flushing, you prophylax with aspirin. So remember, the goal is get people on statins, but if statins don't work, pick one of these, and where they're going to go is fibrates if you can't get a statin, ezetimibe causes diarrhea, niacin causes flushing, treat with aspirin. That's cholesterol.